Good. Right, so do you want me to start to share my presentation, or is it too early?
I think we are live on YouTube now.
Okay. So shall I start? Do you want me to share
I can't
the
hear you well,
presentation?
my dear friend. Please open the first slide.
Okay.
And I will introduce you.
So shall I start?
Yes, I will tell you. Dr. Muhammad, did you share the link for the Facebook?
I shared the link, but you have you should approve it as an admin. I already posted to the group.
1 second. Okay. I can't see it.
You mean the post?
Yes.
I posted it. I will write a new one. Yes, it's approved.
Hmm?
No problem.
I posted it.
I'm doing it right now.
I have posted it.
I can do it, Ahmed. I'm doing it. No problem.
I did. Okay. We will start now.
Okay.
Okay. Good evening, my dear friends from all over the world. It's my pleasure and great honor to introduce my great friend, Dr. Alexander Nossikof, a consultant cardiologist from Bulgaria, and he will talk about the venous thromboembolism, the challenges at the time of COVID-19 pandemic. Let's go, please.
Hello, my dear friends and colleagues. Now I'm starting my presentation. Do you see my presentation all right?
Yes, yes.
Yeah, right. These are my disclosures. I'm moving on. So all of you know that VT is on the rise, and it has been on the rise for the last 20 years. The population is getting older. So there is more pulmonary embolism and more DVTs all over the world, and this will only continue to grow. So this is the the classic figure from the guideline, and you can see that in patients with suspected pulmonary embolism who are stable, we're relying mainly on the D-dimer test and on CTPA. If the D-dimer is normal and the probability of pulmonary embolism is low or intermediate, then these patients are deemed negative, no treatment is needed. If the D-dimer is positive, usually we need to do CTPA for the best rule out of the diagnosis. There is one trick, And this is something that I have been doing for 6 or 7 years. Now it is in the guidelines, in the new ESC guidelines from 2019. You can age adjust the D-dimer. With rising age, the D-dimer gets higher and higher, and actually about 20% of the elderly patients have D-dimers that are persistently above the reference range. So the most simple way to do this is you just multiply the age on 10. So if your patient is, let's say, 80 years old, you multiply 80 by 10, and this gets you to 0.800, which is higher than the usual reference range of 0.500. By this way, you can reduce the number of the unnecessary CTPAs that you can do. CTPA is the current standard of care in suspected pulmonary embolism. It has many pros. The scans take just a few seconds on the modern machines. It gives you a very, very good idea about the thrombotic burden. It identifies very well subtle PEs, which we can rarely see on echo, and it's good to know about that, especially if you are going for CDT. And sometimes these patients are very well indicated for surgery if they have just the subtle thrombus and no distal involvement. You can see very well masses and cancers and tumors. It's very easy to compare the right ventricle to the left ventricle, and by this way to try to measure the acute RV overload. And you can see very easy the pulmonary consolidations, which is very, very important at times of COVID-19. You can do a late phase scan, and you can scan the abdomen, and you can look for cancers. As any technique, CTPA is not perfect. And here comes one of the biggest problems in my country. Virtually, we don't have any hospital with 2 CT scanners. So we can put one CT scanner for COVID patients and another CT scanner for clean patients. So when you have just one CT scanner in your hospital, there is a huge potential for COVID-19 spread. So you have to be very careful. Whom do you scan? Why do you scan them? And what do you do just to avoid cross-contamination? Cost is an issue, radiation exposure is an issue, contrast is an issue. There was one study in New England Journal of Medicine showing no benefit of cancer screening. I have seen many patients with no correlation between thrombotic burden and clinical stability. Subsegmental PE is a problem. And in the developed world, when we do a lot of scans, in some centers, just less than 10% of the scans are diagnostic for pulmonary embolism. This happens because we do the CT for insurance, for defense, and we scan a lot of patients unnecessarily. Unstable patients, intubated patients, are very difficult to be transported to the scanner. And this is where the bedside techniques are best. And this problem has been known for years because CT scanners need calibrations after earthquakes. So when in Japan they have a huge earthquake, all the CT scanners do not work for a few days until they get them calibrated. So people are stuck in their houses, cars, develop DVTs and pulmonary embolisms, and then you can't scan them. So you need something else. It's not just the CTPA and CTPA only. These are the conclusions. It's just the summary of what I have already told you. Keep in mind that CTPA is not 100%, and I have had cases in the past where the pulmonary embolism diagnosis was obvious and the CTPA was negative. I don't know the reasons for that, but this happens sometimes. What we can do, there are 3 techniques. I'll start first with the lung ultrasound. You can do lung ultrasound in patients with suspected pulmonary embolism. Commonly, there are reactive pleural effusions. Commonly, you see wedge-shaped consolidations, B-lines near the wedge-shaped consolidations. But it's very, very difficult for me, and not only for me, to distinguish pulmonary embolism from other conditions based on the lung ultrasound alone. but it is useful when you do it in the context of multimodality imaging. Transthoracic echo does not work very well to diagnose pulmonary embolism. You know that you see right atrial and right ventricular thrombi and pulmonary artery thrombi just in 3 to 5% of the cases. McConnell, I'll show you later that you can see it in cases without pulmonary embolism. And most importantly, you cannot rule out the diagnosis. Even if you have completely normal transthoracic echo, still the patient can have pulmonary embolism. But it's very good for risk stratification and rest stratification, and very good in shocked and unstable patients. And again, and I'm stressing this again, multi-organ ultrasound is the best bedside technique in pulmonary embolism. And you see in unstable patients with suspected pulmonary embolism, the first thing that you're supposed to do is bedside transthoracic echo. If you don't see any signs of RV dysfunction, you have to look for alternative diagnosis. If you see signs of RV dysfunction, you need to consider if it's feasible and available to do CTPA and to proceed this way. The best technique, in my opinion, is compression ultrasounds. In about 50% of the cases with pulmonary embolism, you can quickly see a DVT just at bedside and avoid moving the patient through the hospital to the scanner here and then. You can see mobile thrombi, and I'll show you a case later. Few words about pulmonary angio. This is a patient with normal pulmonary angio, and you see that this patient has CTF. So no technique is 100%. What's the problem in my country? And I suppose not only in my country now. We have lack of hospital beds. We have a lot of units that have been, in my city, a lot of units have given COVID-19 beds. So they're waiting for COVID-19 patients, and the beds cannot be used for other patients. So it's very difficult for me now to move a patient to the hospital. We have a lot of quarantined units where some of the personnel, of the medical personnel, got infected, tested positive, or was in contact with COVID-19 patients. So we cannot use the beds there. So what I think we need to move to is to try, if we diagnose a patient with pulmonary embolism or with DVT, we need to try to assess which patients can be safely treated at home. There are two ways to do that, and this is again the ESC 2019 guideline. You can look at PESI class, or you can look at Hestia criteria. And if the patient is low risk, and if the patient does not have RV dysfunction, you can consider the patient to go for early discharge or for home treatment. Ideally, he should have a normal troponin test as well. This is the BTS guideline, and it's very similar to the ESC guideline. Either you go for Hestia criteria, or you assess PESI or simplified PESI. If no RV dilation, if biomarkers are normal, then you consider the patient to go home if there is no other reason for the patient to be in hospital. These are the Hestia criteria. You do not need to remember them. You just can go to MDCalc and input them, and they will be calculated for you. There is very huge science behind the Hestia criteria. They are considered to be working better than the older guideline from 2014, and this is why they are suggested for use. These are the modified Hestia criteria, which are quite more simple. They were used in one study with rivaroxaban for VTE of 100 patients, which was a successful study with no recurrences. However, 3 of the patients had recurrences once the rivaroxaban was stopped. Again, the validation studies, very, very good evidence. If you want to calculate PESI, again, you can go to MDCalc and calculate the PESI, and that's very easy. This is an algorithm that we have developed in my previous hospital, where we were heavily using compression ultrasound. So we were always going for age-adjusted D-dimer in patients with low or intermediate probability. If it was above reference range, we had the possibility to do compression ultrasound in all patients. And if it was positive, VTE was confirmed and treatment was started, and we were doing CTPA for other reasons. This is not something new. It's very old, and you can see it in the guideline of ESC. In patients who have pregnancy, we are afraid to do CTPA there, so you can see that, again, they rely heavily on compression ultrasounds. Very old paper from Duketis from 2005, trying to identify which patients with DVT can be treated at home. So these are the patients with swelling of the entire limb. The patients that cannot be treated at home are patients at risk of venous limb ischemia, extension of the DVT to iliofemoral veins or inferior vena cava, symptomatic pulmonary embolism, active bleeding, etc. These are about 20 to 25, sometimes 30 in some series of the patients. Most of the patients with DVT can be safely treated at home. So I'm not really sure why at this situation, and the patients themselves do not want to go to the hospital. Cochrane review from 2008. The evidence is low quality, but it actually suggests that the patients treated at home with low molecular weight heparin have lower risk of recurrence. We can speculate it's due to early mobilization or other things, and you see what they say here. Home treatment is likely to become the norm. And I think this COVID-19 situation is just catalyzing this. So we are starting to consider who has to be treated at home at much earlier stage. I'm moving to my clinical cases now. So you can see this classic wedge shaped on the left, this black triangle, and it has a B line here. And the patient had a DVT. And the funny thing is that at the time that we did this, our CT scanner was broken. So we actually managed to have the diagnosis without CTPA. How did we get to the wedge-shaped artifact? We just asked the patient to show where does he have the pleural pain and put the transducer there. And this is a simple trick in patients with pleural pain, how to catch VTEs and pulmonary embolisms. You can see a DVT in a patient with multiple myeloma. She came to me a few weeks back, and she didn't want to go to hospital or to do anything. So what I did is I gave her a bit of enoxaparin, and then I prescribed her Riva twice daily. And then I moved her to 20 milligrams of Riva. Another patient with peripheral lung tumor, another popliteal thrombus. You can see here that the thrombus is not very well fixed. The reason here is he was not anticoagulated well. So they were giving him once daily dalteparin, and the dosage was not enough. And this was the reason for this thrombus propagation. You can see the tumor here, and you can see the pulmonary embolism here. Another thing that we did here, we did lung ultrasound, and we assessed that the tumor is good for true cut biopsy, and the patient had true cut biopsy, and the diagnosis of lung carcinoma was confirmed. Now, these are the classic two studies of patients on edoxaban and rivaroxaban, Hokusai VT and Select D, and you can see that edoxaban and rivaroxaban are actually better than dalteparin in terms of recurrent VT. There is some increase in major bleeding, and it comes mainly from patients with GIT cancers. And this is now in the guidelines. So we have been doing this for years, off-label, especially with rivaroxaban. But this is now in the guidelines. So in patients with cancer-related VT, we can consider giving NOACs now, and in particular this NOACs. Very fresh study with apixaban. again, apixaban against dalteparin, and you can see that apixaban is better than dalteparin in terms of recurrent VTE, but here the bleeding is similar. Another case, 40-year-old male, and this is one of the rare cases when you have triple negative lung ultrasound, compression ultrasound, and transthoracic echo. So the patient had completely normal echoes, troponin was normal, BNP was normal, and D-dimer was very high. I decided to scan him. He refused to go to hospital, and I gave him rivaroxaban, and he's fine now. I recently did a stress test on him, and he was completely fine. Another study, hot study with 500 patients on rivaroxaban, just 0.6 VT recurrence and fatal pulmonary embolism. The study was stopped early. And now we are getting to the point. Pulmonary embolism, VTE, and COVID-19. Random association or not? Well, it's not a random association, and now we know that because there have been multiple case reports of VTEs, DVTs, pulmonary embolisms in COVID-19 patients. This patient is with pulmonary COVID, and you can see the large VT in the left and the right pulmonary branch. It's a case report. I won't stop on this. People will speak on this later. Just a few words on the CT scans. They're very good to diagnose the disease, but you cannot rule out the disease. So even if the patient has a normal pulmonary CT scan, and you see him, it doesn't mean that the patient is not infected. Here on the left, and you have to be very careful with that, it's my old ARDS patient, and you can see how dilated is the RV, and you can see that it looks like McConnell. On the right, another patient with RV myocardial infarction. Both of the patients do not have pulmonary embolism. So you have to remember that McConnell can be present not only in pulmonary embolism, but in any acute RV overload. And actually here below, this is a link to Twitter, and you can go later to it, you can find it, of a COVID-19 patient with ARDS and McConnell who didn't have pulmonary embolism. So even seeing a McConnell does not give you diagnosis. I'm coming to my conclusions, and I'll move very fast to them. So at times of COVID-19 pandemic and massive lockdowns, we can speculate that people are just sitting in front of their tellies, they are not physically active, and this will increase the number of VTE cases. COVID-19 itself is very prothrombotic, especially during the cytokine storm phase and the systemic inflammatory response. There have been multiple reports of VTE now. Prophylactic regimens are suggested by most guidelines, but many Italian and Spanish doctors use higher prophylactic dosages than usual. And you can see here, that's a suggestion in a document from UK, from Imperial College. I was not able to find the source. Depending on the D-dimer and depending on the weight of the patient, they suggest for us to adjust the enoxaparin dosage. And as you see, most of the dosages are twice daily. Another document suggesting to use serial D-dimers, follow up, and to see what are the D-dimers, just to check the indications for anticoagulation. You have to be very careful with the patients that are already on VKA. This is a suggestion from NHS. So if the patient is low risk and with DVT and pulmonary embolism, and if the risk of recurrence is low now, consider stopping the warfarin. In the rest of the patients, consider switching to DOACs. This is to eliminate the risk of COVID when going to anticoagulation clinics. You know all these patients that you cannot switch to DOACs, so I won't go into detail with that. We will continue to encounter VTE during COVID-19. My personal opinion is that we will continue to encounter it more and more and more, especially in intensive care patients with COVID-19, if we monitor them closely, even if they didn't have DVT in the beginning. In a week or two, they will have either thrombosis of the central venous line or DVT somewhere or something. This disease is highly dangerous and highly thrombotic. COVID-19 infection can present in the same way as pulmonary embolism. It's very difficult to distinguish both diseases because D-dimer increases both in patients with COVID and with pulmonary embolism. I consider that you use both compression ultrasound and lung ultrasound because compression ultrasound will guide you in choosing the patients for therapeutic anticoagulation, and lung ultrasound will help you to see the typical COVID patterns. Again, this simple table showing you how to deal with age-adjusted D-dimer and compression ultrasound. And you'll have to reassess all your transthoracic echo schedule. It is suggested that TTEs have to be done only if they change management. It is suggested that you use focus views and rapid assessments wherever possible. The best way to deal with COVID-19 patients is to use portable wireless devices that can easily be covered with plastics. TEs should not be done. I suggest if you do TTE, you combine it with lung ultrasound and compression ultrasound where appropriate to increase clinical utility. There is a document which shows very well everything, how it should be done, an EACRI and EAC document. And this is from the recent guideline. You have, if you have a patient with suspected or unconfirmed COVID-19, you do a fast assessment of left ventricle, right ventricle, valves, and pericardium. Again, most patients with DVT can be safely treated out of hospital. You can directly move to apixaban and rivaroxaban without preceding low molecular weight heparin. In cancer, there are some things in the product characteristics and the label. Many patients with low-risk PE can be treated out of hospital as well. Who cannot be treated out of hospital? Now, this patient was prepared for discharge. He had successful thrombolysis for pulmonary embolism. He was completely stable. And you see these giant thrombus on the left, which would kill him, obviously, if we discharge him. So we did original thrombolysis here, and you see that the thrombus dissolved. Again, access to both CTPA and hospital beds can be very problematic, and the most important thing, we have to consider out of hospital treatment whenever possible for our VTE patients to limit the patient and the staff exposure. Consider weight-adjusted low molecular weight heparin and NOx. This is the most important table. You can find it in the guideline. Consider drug interactions. If patient is on HIV treatment, then you cannot give NOx. And this is the proposed flow chart if the patient is on chloroquine and azithromycin and the QTC is prolonged. And talk to your patients, please, not to stop the ACE inhibitors, the ARBs and the ARNIs. This is a huge problem, and I've already had a lot of patients with hypertensive lung edema and other things due to stopping the drugs. Now the COVID-19 phases. Here, CT, X-ray, everything can be normal. Even the PCR can be normal. Here we go to the pulmonary phase, and this is the host inflammatory phase. So we have three phases of the disease. Keep in mind that the nasal PCRs are positive only in 63% of the patients, and the pharyngeal swabs in only 30% of the cases. So you have to be careful. Negative PCR does not mean that the patient is not infected. The Chinese say that the CTs work better than PCR. As you see here, there are CTs in many negative PCR patients that are positive for COVID. And my final slides put everything in clinical context. Both VTE and COVID are very difficult diseases and very difficult to rule out. Ultrasound is just extension of the brain. It's the new stethoscope. use multimodality imaging and clinical context if you want to deal well with these patients. It's unavoidable that you will have to do CT scans in some of the patients, but always consider the COVID-19 infection spread possibility. And I'm always asked this question, so I've put 2 slides here. How can we say if the patient has heart failure or ARDS or pulmonary fibrosis? If you look at the pleural line here, it's very, very rough, and this cannot be the case in heart failure. These are 2 cases with pulmonary fibrosis. This is a patient with heart failure, and you see how smooth is the pleural line. So this can help you diagnosing the patients at bedside. Thank you for your attention.
Thank you so much, my dear friend, for this excellent presentation. And I'd like to highlight your suggestion for diagnosis of pulmonary embolism, especially in the COVID-19 era, which consists of the triad of transthoracic echo, lung ultrasound, and compression ultrasound. This will this can avoid unnecessary CT scan, especially in the hospital that don't have many CT machines to decrease the risk of infection, especially for the healthcare provider. I'd like to ask you about, do you think that pulmonary microthrombi have a role in the pathogenesis of the lung affection in COVID-19 patients, with some reports suggesting that the ARDS parameters on the mechanical ventilation are not appropriate for all patients with COVID-19? Do you think it is rather a pulmonary thrombi and they will benefit more from anticoagulation rather than the invasive ventilation?
Well, I had one slide on that, which I on purpose didn't talk about. There are different phenotypes of the COVID-19 disease. So one is the ARDS-like, which can probably be ventilated as an ARDS. I'm trying to find the slides. Okay. So this on the right is the classic ARDS type, and this probably has to be, I don't know, ventilated as an ARDS. Here, the patient can be heavily desaturated, but as you see, the involvement here is not, the lung involvement is not so bad. So there are several possible explanations to that. One is vasoplegia. So the pulmonary arteries do not are vasoplegic, and they're not able to constrict to the hypoxic areas. The other explanation is multiple microthrombi, and we know from autopsy series that the patients with COVID have both microthrombi and macrothrombi. We know this from CT scans as well, because they have wedge-shaped consolidations, typical for pulmonary embolism. So these patients have to be treated in a completely different way to these patients here on the right. I suppose Hatem will speak more about that, but it makes to me more sense here to try with non-invasive ventilation and with nitric oxide or murinol or other pulmonary vasodilators. I hope I answered your question.
Yes, yes. Another question, please. We agree that the low-risk patients with pulmonary embolism, we can send home or early discharge from the hospital. High risk should be hospitalized. Then we have the intermediate category, which is divided into intermediate high and intermediate low. I think intermediate high should be also hospitalized for monitoring for any hemodynamic instability. What do you think about patients with intermediate low risk pulmonary embolism? Can we offer them an early discharge or home treatment in the era of the COVID-19? I think
I think it depends very much on how is the RV function going, and if the patient was well assessed regarding the DVT, if he has any mobile DVT or anything, because these patients here, the intermediate low risk, they're usually troponin negative, they are usually BNP negative, they can have reasonable RV function, and if their PESI class improves, and if they don't need oxygen or anything, why not? Why not discharging them? I don't see a problem with that. But if the patient is with, for example, with RV dysfunction, and this RV dysfunction is persistent, and he has even a small but still mobile thrombus in the leg, this means that if this thrombus goes up, the patient will die. So you have to be careful, because this group is not fully homogeneous. There are different patients.
Yes. Yes, totally agree. Dr. Muhammad, can we have the questions from the audience, please?
Okay, Dr. Ahmed, the first question. You hear me? I hear you well.
Yes.
So the first question from the floor. Do you use the sepsis-induced coagulopathy score in deciding prophylactic or therapeutic anticoagulation in COVID patients? Do you use it or not in your practice?
If the question is regarding the COVID-19 patients,
yes.
My opinion is that all patients need at least moderate anticoagulation. I don't think that it's appropriate, but this is my opinion. This is not based on evidence or guidelines or anything. I think that enoxaparin 40 milligrams, which is the usual prophylactic dose, is not enough for most patients, even in normal life. So when we give enoxaparin 40, if it is a high-risk patient, it will not be enough in him. If it is a low-risk patient, for example, with small orthopedic surgery, he doesn't probably need enoxaparin. So what I suggest is using at least twice daily, 40 or 50 or 60 milligrams of enoxaparin in all patients. Once you see a DVT or very high D-dimer or other high-risk features, or you look at the central line and you see that he has a thrombus, you just move to therapeutic regimen. I personally don't use SOFA score, but I'm not an intensivist on deciding on my anticoagulation regimens.
Okay, it's clear. I will go for the second question. Those who will be discharged, should we start oral NOACs from day one, or do you like to start with parenteral therapy, enoxaparin, for example?
That depends, and there are several different scenarios here. So in DVT, first I'll go on the clinical side, and then I'll go on the other side. So on the clinical side, if it is a DVT, and if it doesn't have a mobile thrombus, and if it is not very proximal with iliofemoral extension to the inferior vena cava, I don't worry. I can start with NOACs from day one, and I can start with both apixaban and rivaroxaban, and I have quite a lot of experience with that, and everything is okay. If it is pulmonary embolism, it is not the same, because you need some time to get the diagnosis. You need some time to get the CT. You need some time to get the patient moving. And while waiting for all the tests to be done and for everything, maybe it's a good idea to keep the patient on low molecular weight heparin. Now, in my country, we need some technical time for a NOAC to get prescribed. So I write a consultation to the patient. I put my stamp, I put my signature, then the patient goes to the GP, then he gets this prescribed, then he has to go to the pharmacy. So in the worst case, if this happens Friday evening, he will not get his NOAC until Monday afternoon. So it is very common to use low molecular weight heparins just to bridge towards the availability for the NOAC to the particular patient. And I personally, in pulmonary embolism, I prefer rivaroxaban, because we have 3 weeks of, we have longer high dosage but I can't prove that this is better. It's just a preference, because this choosing 1 week and choosing 3 weeks, it was not based on any evidence. I hope this answered your question. I personally find it very well suited for the patients to be for a day or two on low molecular weight happenings and then to move on NOACs.
Okay, Dr. Alexander. The second question from our dear colleague, Dr. Fadi Aziz. He is asking if you would like to anticoagulate those patients with stable acute VTE who have cancer as well. Regarding this special group that needs hospitalization at least a couple of days, would you like also to hospitalize these patients, although they have low risk DVTs?
Stable acute DVTs with cancer?
Yes, with cancer. The first question will be hospitalization, yes or no? And the second question will be anticoagulation regarding this patient group.
So if you have a patient with cancer, the most important thing is this patient at high risk of bleeding? How is his renal function? Is this GIT cancer or not? If this is not a GIT cancer, if his renal function is reasonable, if his platelets are okay, if he is at not so high risk of bleeding, then I think you can anticoagulate directly with a NOAC and send him home. Like one of the cases that I showed you, it was a multiple myeloma case, and I gave her enoxaparin, sent her home. She got the prescription for rivaroxaban, and she was treated quite all right with that. It's a bit different always with pulmonary embolism. I think with pulmonary embolism, maybe just 1/3 of the patient can be easily stratified as low-risk patients and sent home. The rest of the patients, they need at least 3 to 4 days of treatment and observation in the hospital. I hope this answers your question.
That's clear. So please, Dr. Ahmed.
Thank you so much, dear Dr. Muhammad. Thank you so much, my dear friend, Dr. Alexander Nossikof, for this elegant presentation. And now we will move to the next speaker, Dr. Hatem Soliman, cardiothoracic intensivist in London, UK. And he will talk about ventilation and lung ultrasound. Dr. Hatem, are you ready? Dr. Hatem, please unmute your mic.
Do you hear me? Good evening, everyone.
Good evening, my dear friend.
How are you? Do you see my screen?
Not yet.
All right, let me get my screen on. Just one moment. I think I have to log out and log on to the meeting again, Dr. Ahmed. Just 10 seconds. I apologize for this. Just to be able to share my screen. Okay, just 5 seconds. See you shortly.
Okay. Okay.
Thank you. Thank you.
So, Dr. Ahmed, there was another question from the floor. It was not directly connected to our topic from Dr. Alexander, but we can address the question right now. We have a couple of seconds. I will read the question to you, and we can discuss it together until Dr. Hatem is ready.
Okay.
So the colleague is asking, he had a patient which came in the ER with acute pulmonary edema, aortic stenosis, ischemic cardiomyopathy, and he did not send the patient to CT because of the clear diagnosis, I think. And then he was asked from his senior, from his boss, why not you send the patient to the CT to exclude COVID?
Okay. Well, in such case, I think the most important is the decision of the directly treating physician, because when a patient has aortic stenosis and has pulmonary edema, this is life-threatening. And until you stabilize this patient, you can't really safely do a CT scan. So you need to get this patient to the CCU or to ICU and try to stabilize him. Maybe you can use other methods to try to confirm the diagnosis. You can do PCR tests, you can do serology, you can do whatever. But I support this physician in his opinion that it's not safe in this case to do CT. If the patient is intubated and in the CT scanner they have good conditions for an intubated patient to be scanned, well, then maybe it's different. But otherwise, I think it's okay.
Okay, I think Dr. Hatem, we see your presentation. Or would you like to proceed?
All right. Good evening, everyone, and sorry for this brief technical delay. Thank you, Dr. Ahmed, for organizing this important webinar. And I have a very brief presentation on the use of ventilation and lung ultrasound in COVID-19 patients. So moving on to my presentation, I would like to, in the beginning, to highlight probably one key message. If I want to summarize the whole idea of my presentation from what we saw in these patients so far, is that we need to be patient with them and we need to give them time on the ventilator if we decide that they will need to be on mechanical ventilation. So as we can see in this slide, which is showing us the time course of the development of ventilator-induced lung injury in patients who develop ARDS induced by mechanical ventilation, which is about 40 hours. And it's important to put in consideration the harmful effects of mechanical ventilation and the harmful effect of the potential negative inspiratory pressure of the patients who are breathing spontaneously. And I'm starting with this because we know from our evolving knowledge and experience about COVID-19 that these patients have various potential mechanisms underlying the problem they have. They have probably an element of lung vasoplegia due to loss of the hypoxic pulmonary vasoconstriction, which consequently probably lead to elevation in the nitric oxide level and also probably reduction in the production of angiotensin II, which all lead to alveolar flooding and a massive VQ mismatch. It's a different type of VQ mismatch that we did not often see previously in the usual patients presenting with respiratory failure, because this type of VQ mismatch is typically or commonly characterized by normal ventilation. That's why they come usually with a sort of preserved lung compliance, but they have an increased lung perfusion due to this element of vasoplegia and alveolar flooding. And this massive change in the ventilation perfusion ratio is probably the cause of their severe hypoxemia. And this is also an illustration of the effect of the initial lung injury on the development of alveolar edema due to capillary leak, with worsening in the lung mechanics and gas exchange, which lead to a vicious cycle of further capillary leak and a progressive worsening of the lung mechanics and the hypoxia. So this is one theory, and another theory could be the development of microthrombi. As Alexander said, we know that this disease causes high thrombogenic potentials, and we see patients developing PEs, we see patients developing very high levels of the D-dimer and fibrinogen. So the role of ventilation will be decided upon understanding the progression of the disease. So once we decide that the patient will need to have a sort of ventilation, we need to see whether they will be eligible for non-invasive ventilation or they will require intubation and ventilation. So we often, I mean, I work in cardiothoracic intensive care, and we often have patients already intubated in our unit. We don't have emergency department, so we don't intubate patients coming to the hospital. We usually have them intubated and refer to us from another hospitals. But we do know from our colleagues working in accident and emergencies across the country and also in other countries in Europe and in the world affected by the COVID-19, that these patients may have severe levels of hypoxia without symptoms, or in other words, without significant dyspnea. And this probably could be explained by the compensation they do by increasing the levels of tidal volume rather than increasing the respiratory rate to match the respiratory needs. So you can see patients with saturation of 60, 70%, but they are not dyspneic. And that's why there were trials of starting non-invasive ventilation on these patients, especially if they don't have significant affection of the lungs in the beginning in their imaging. So we have some advantages from starting non-invasive ventilation. It may help the oxygenation. It may reduce the swings in the negative inspiratory pressure triggered by breathing. Especially, we do know that these swings may be very harmful for the progression of the disease, because if the patient is working hard to breathe spontaneously with an acute fluctuations in the intrathoracic pressure, this can cause cycles of increase and drop in the venous return, which will lead to cyclical lung edema and a cyclical hypoperfusion of the lungs due to these acute swings in the venous return, which may cause a progressive worsening of the oxygenation. But we do see in many centers that the intensivist and emergency physician opt to intubate these patients early on and not trying non-invasive ventilation because of the understandably risk of aerosolization and a very high infectivity level of these patients coming in the early beginning with respiratory failure. But on the other hand as well, when we try non-invasive ventilation, it may be harmful for the right ventricular function, and it may cause or trigger the development of acute kidney injury on the long term. And these are the two important phenotypes of the COVID-19 as explained or suggested by Luciano Gattinoni. We have the common type L phenotype, the one at the top of the screen, which is commonly presenting by preserved lung compliance, not typical ARDS presentation. They have severe hypoxemia and they have no recruitability or very low recruitability of the lung. And they also have a low of the lung, reduction of the lung elastance. And actually these two images, these two CT images are from the same patient. The first patient was breathing spontaneously for 7 days. And we see in the CT scan the typical peripheral ground glass infiltrations, which are typical for COVID-19. And after the patient left for several days, breathing spontaneously, and then tried for longer intervals on CPAP, non-invasive ventilation, with probably trials of giving him fluids because his blood pressure was dropping, we caused iatrogenic transformation of the patient from the classic type L to the other type, which is the type H. The type H phenotype of the COVID-19 is the type almost similar to ARDS, where you see these very bilateral dense consolidation and extension of the ground glass opacification. And you can notice here that the level of hypoxemia is almost similar in both phenotypes, but the lung mechanics are very different. So before deciding for which types of ventilation we are providing and which modes of ventilation and which settings of the ventilator we are going to put, we need to know which type or which phenotype of COVID-19 we are treating. So on the left, type L, on the right is type H. And setting the ventilator will be decided upon knowing the compliance of the patient. So as I just mentioned, that type L is usually characterized by reduction of the elastance, reduction of the VQ ratio, reduction of the lung weight, and lower recruitability. This tells us that you should cautiously use PEEP in these patients with type L. Otherwise, you will cause overdistension and you might not help the lung, but you might cause injury and more harm to the lungs. But on the right side, the type H, which is the classic or near to the classic ARDS type, they have high elastance, increased shunt level, high lung weight, and this is the type that may benefit from recruitment with PEEP. So how do I set the ventilator? Again, so let's say we decided that our patient is the type L, which is commonly the type we see in our units, but we also see the other types as well. So type L, you can use either volume control or pressure control mode of ventilation. There is no definite answer to the mode of ventilation. So it depends on what you are familiar to use. So the mode of ventilation, as some people call it, is like the type of car. So whatever you're familiar of driving, whatever you are good at, do it, whether it's volume control or pressure control. The tidal volume, we noticed that, and some authors noticed that these patients, because they have normal compliance, you should not give them the standard lung protective ventilation that we often give for patients with ARDS. Because if you give them low tidal volume, you put them at risk for resorption atelectasis, and this is not a good thing in such patients. So you should give them a tidal volume in the range of 6 to 8 milliliter per kg. You should start with high FiO2, high oxygen, and then try to titrate depending on your targets of oxygenation. We usually target a PO2 more than 8 and saturation more than 92%. Your respiratory rate, you don't also give them high respiratory rate, unlike ARDS. So you try to aim for a respiratory rate less than 20 breaths per minute. Your PEEP, as I just mentioned, you need to be cautious with the PEEP. They can usually be managed with PEEP of 8 to 10, not more than that. Proning was found useful in these patients, which was a bit counterintuitive because we do know that proning is classically useful for patients with dense basal consolidation. And these patients do not have usually basal consolidation. When we scan the lungs with lung ultrasound or CT, we often see the pattern of curtain-like B-lines in a patchy distribution with no lobar consolidation. Or on the other hand, with CT, you often see the ground glass appearance with no consolidation. But we found with experience that these patients do well with proning, and this probably could be explained by the redistribution of lung perfusion with proning, and also some suggestion that these patients have microatelectasis, which could be relieved or improved by proning them. So we do series of proning for these patients, and some center even do extended series of proning, up to 5 or 7 proning sessions. And the proning usually is from 16 to 18 hours in proning position, and then the rest of the 24 hours will be in supine position, and then you can repeat that every day if clinically indicated. And of course, when these patients are proned and managed on the ventilator, you have to sedate them and paralyze them. They have to be comfortable. And I think the most important message I want to give from this presentation, one thing, be patient, because one of the very dangerous and one of the very bad consequences of ventilation management in these patients is our temptation to wake them up early when we see the FiO2 improving down to 35 or 40%, and then we attempt to extubate them, and we suddenly see these patients deteriorate if they are extubated early on, which is one of the challenging problems that can transform the patient from type L to type H when they are re-intubated, and then the mortality rates gets very high. So patience is very important, and we noted that these patients usually take on the ventilator at least 7 days, and ideally 10 to 14 days, even if they are requiring lower FiO2. But it does not necessarily mean that these patients are ready yet for extubation. And I found that lung ultrasound can be useful and guiding in this setting. I have seen several patients with improving FiO2, 35 to 40%. And when I scan the lungs as part of my daily assessment of these patients, I still see a significant degree of alveolar edema and curtain-like B-lines across the lungs, which is an indicator of the level of aeration. So I often feel more comfortable to extubate my patients when I see predominant A-lines pattern, the predominant pattern of normal aeration across the lungs. We don't expect the B-lines to disappear, but I'm talking about the predominant pattern across the lungs in different zones. So my key message here, be patient with these patients. Don't wake them up early and don't extubate them unless you are comfortable. Usually 10 to 14 days is the average. There's no solid cutoff or solid number. It is all your clinical judgment, but this is what we saw and our colleagues saw in other centers as well. The other type, the type H, is similar to the classic ARDS type. And again, the mode of ventilation, you can use volume or pressure control, depends on what you are familiar with. And here, because they have dense consolidation in the lungs, they have low compliance, you would use the lung protective ventilation. And the lung protective ventilation, for those of you who are not familiar with, is the settings of giving the patient low tidal volume and high frequency if they have low compliance, because they have very stiff lungs due to the consolidation of the lungs. And such stiff lungs is not easy to ventilate. So try to compensate this by increasing the minute volume, by reducing the tidal volume to reduce the plateau pressure, and avoid worsening of the lung mechanics and injury of the lungs by the mechanical ventilation. And to try to wash out the CO2, you increase the respiratory rate. And we often allow a degree of permissive hypercapnia on these patients, meaning that you will not be able to clear the CO2 completely. You would allow a degree of respiratory acidosis, which can be variable between 7.25 to 7.20, allowing the CO2 to increase, keep them sedated, paralyzed, but your aim is to maintain the plateau pressure, which is the intra-alveolar pressure, less than 30. So low tidal volume, 4 to 6 mL per kg. Again, your oxygen will be titrated according to your aims of oxygenation, PO2 more than 8, saturation from 88% to 92%. Respiratory rate will be on the higher side because you try to give them a bit of higher minute ventilation, but again, you will allow permissive hypercapnia. Your PEEP, you will be allowed to use higher PEEP. And intensivists will know that we have a table of correlation between the PEEP and the FiO2, and we have a sort of bundling of the level of PEEP as correlated to the FiO2, which you should not use it in the type L. You should not couple the PEEP with FiO2 to avoid recruiting the lungs because they don't require recruitment. But in the type H, this type, you can couple the FiO2 and the PEEP, and you can go up with the PEEP if you have high FiO2 requirements to try to reduce the FiO2 to the minimal required level. Proning is needed usually every day in the type H as well to help redistribution of perfusion and helping improving the oxygenation and opening up the atelectatic airways. Sedation and paralysis is a must. And again, you have to be patient as always. So now we intubated the patient. We followed the patient up every day by clinical assessment, by lung ultrasound. We did CT just if we can for these patients to help identifying the lung pathology in accuracy. And now we decided to wean the patient. So when you wean the patient, remember COVID-19 is a long-lasting disease. You should avoid early weaning. And I'm repeating that, I'm stressing on that. It takes an average of 10 to 14 days on the ventilator, which can be less, can be more. And avoid the negative early inspiratory swings when they breathe hard spontaneously. We are usually thinking in a positive way when we are weaning patient to let them breathe on her own, breathe hard, because we think that we are training the respiratory muscles and letting the diaphragm work. but that doesn't prove useful in patients with COVID-19, especially in the beginning of the disease, because this can have damaging effects on the lungs. And it is called a form of self-inflicted lung injury from the active breathing early on the disease when the lung is not healed from the disease. So when we decide that they are ready for extubation, we saw that extubation CPAP is useful. So in our unit, we have the CPAP hood, which is applied all over the face. But I think any form of CPAP is useful because these patients tend to de-recruit easily after extubation. Even if you do it after 10 to 14 days, they are still at risk of de-recruitment and collapse of the airways. So extubation to CPAP is advisable. And we also tend to keep them on the CPAP for longer intervals, especially in the first 24 hours. And then we come to the role of lung ultrasound, which is useful to monitor progression and guide weaning from the ventilator. We use it usually to monitor our recruitment, to see the level of aeration in the lungs, to see the effect and response to proning and help weaning from ventilation. And this is a study which shows you the significant increase in the number of publications on lung ultrasound from the 70s until now when you search it on PubMed. And we all know the advantages of using ultrasound in the point of care. It's very immediate, available at the bedside, repeatable. Lung ultrasound is not difficult to learn, and you will have a steep learning curve if you learn it well under good supervision. It is rapidly applied at the bedside. It saves cost by reducing the number of X-rays done on the unit and even trying to reduce the number of CT scans performed. And it reduces exposure to radiation, and it reduces the exposure of healthcare professionals to the COVID-19 patients if you are avoiding moving the patient out of the bed space and reducing the requirement for doing CT scan. I'm not saying that the CT scan will be replaced by lung ultrasound. CT scan is still the gold standard in imaging the chest, but lung ultrasound can provide useful and can be correlated in a positive way to getting important information, which reduces our need for CT scan. To perform lung ultrasound, you have different probes, but the main probes that you can use in the intensive care is the curvilinear probe, the low frequency transducer to image the parenchyma of the lung, to monitor for aeration and seeing the normal aeration or the loss of aeration or the moderate loss of aeration in the form of B lines, which is common in COVID-19. And the other probe is the linear probe, which is the high frequency probe, very good in seeing the pleura and looking at the pleural health and checking if there is any irregularity, any pleural thickening, or the presence of subpleural consolidation, which is important finding in patients with pneumonia in general, especially in viral pneumonia and COVID-19. The cardiac probe can be used as well. And some people were asking whether we can use it. Yes, we can use it. I mean, it gives you less depth than the curvilinear probe, but it is a good probe to be utilized, especially as part of your echocardiography study, as an extension of your echocardiography examination, and it has a smaller footprint, so it fits easily in the intercostal space. And these are the different zones in the lung. There are several protocols for dividing the lungs into zones for doing the lung ultrasound. This is one of them, and this is the one I commonly use. You have 6 zones on the right and 6 zones on the left, 2 anterior, 2 lateral, and 2 posterior. It might be, or usually difficult to get these posterior zones in mechanically ventilated supine patients, but I try to get as posterior as I can, posterior to the or behind the posterior axillary line to get the lowest part. And as we always say, the devil always hides in the backside. So you have to try to get as posterior as you can when you scan the lungs. The horizontal imaginary line here is almost the nipple line. And the location of your probe is depending on what you are looking at. In pleural effusion, you put your probe at the costophrenic angle. In heart failure, you look at the dependent zones. In pneumothorax, you look at the non-dependent zones for any signs of pneumothorax. And these are typical clips of a patient with COVID-19 where you had very thickened irregular pleura, subpleural consolidation. This is with a linear probe. And for example, if you look here, the pleura is a bit thickened, but it is not very irregular. And you see some vertical artifacts arising from the pleural line, which could be B lines if they are extending to the far field, if we see with the curvilinear probe. But if you compare this to the pattern of the irregularity of the pleural line here, you can see clearly how the pleura is very thickened, irregular, with big subpleural consolidation, which is this hypodensity under the pleura. I see this quite a lot in patients, especially the sick ones admitted to the unit early on the disease. And when the patient heals with time, you start to see improvement in the lung thickening, reduction in the lung thickening, and sometimes we see reduction in the size of the subpleural consolidation. And when you scan the patient with the curvilinear probe, this is very typical. It is typical for ARDS, but we see it very common in patients with COVID-19. This curtain-like patchy alveolar edema. So the B lines are vertical-like comet tails, which reflect increase in the extravascular lung water. So increased or the presence of fluid in the interstitium or alveoli can cause the presence of these vertical comet tails. And here you don't often, or you don't even see isolated B lines because they are plenty, they are a lot, and they are combined together in a confluent way to make this shiny white curtain. So the normal aeration of the lung is almost this black part with the pleural line here, and this mirror-shaped artifact of the pleural line, which is the A line. So this is an area of preserved aeration, very adjacent to an area of moderate loss of aeration, where you see this curtain-like bright B lines. Why I'm saying moderate loss of aeration? Because when you have loss of aeration completely, you will not see B lines, you will see consolidation, which is the transformation of the air into tissue instead of fluid. So you have the air, you have the fluid, you have the tissue. A pattern, B pattern, and C pattern. Air, A lines, B, B lines, C pattern is consolidation. And here you can see the irregularity and thickening of the pleural line. And we have also the lung aeration score, which is one of the scores proposed to get an idea of the degree of aeration. And you can do the scoring on a daily basis, or more than that or less than that if you think it is useful. And it's a tool that could enable you to monitor the progression of aeration in these patients. And when I do that, I see the progression of the scoring and the reduction of the number of the score, which reflects an improvement in the aeration of the lungs. And this is the same patient after almost 10 days of ventilation. You can see the improvement of the pleural line and the reduction of the thickening of the pleural line. And here with the curvilinear probe, you see more black and you clearly see bigger areas of A lines, predominant A lines, and few B lines appearing laterally here, and almost here, almost A lines across the zone. But remember to examine the lung systematically in all the zones. So clinical benefits of lung ultrasound are quite plenty. It is useful for prognostication. Some centers in Europe use it for triaging the patient to decide which is the clinical pathway for the patient, whether they will be admitted to the hospital, managed at home, or admitted to the intensive care, depending on the pattern of aeration and the clinical manifestations and the level of hypoxemia. It can be utilized for risk stratification and assessing disease progression. And this is the data set released from the Intensive Care Society, showing the different patterns observed in patients with COVID-19, whether it is the predominant type B, the predominant B lines in patients with the L phenotype, or the predominant consolidation in patients with the L phenotype, with H phenotype, and consequently thinking of a clinical decision making based on that, whether you will prone them or give them PEEP. But remember, we should apply PEEP carefully to patients with type L, and we can prone them to help improving the oxygenation by redistribution of the lung perfusion. And don't forget the integrated approach. It's very important to put in mind that you will have to use all the imaging modalities that you have, scanning the heart, scanning the lungs, looking at the pleura, looking at the IVC, the deep veins, and also scanning the diaphragm. This will give you an idea about the patient overall, and put this all together in the clinical context. Imaging should not replace your clinical decision making. And we have limitations for it, or like any other diagnostic modality. It may miss pathologies deep within the lungs, limited evidence-based data. It is still very evolving field in imaging, and the potential for human transmission of COVID-19. And let's admit it, we know very limited information. We have very limited information about this pandemic. Most of our practice now is based on experience, very limited evidence, and we are still in the very beginning of our understanding of this disease, which is a huge challenge for every one of us. So my take-home messages, therefore, will be patient with your COVID-19 patients who are ventilated, give them time, allow the lungs to heal. New disease with very limited experience on therapies. We are still learning on the go, so we have to be very careful when we are managing these patients. Lung ultrasound can be useful if applied at the bedside as a monitoring tool, and we should always remember the integrated approach when we are managing these patients. Try to get all the imaging modalities together in the clinical context. Thank you.
Thank you so much, my dear friend, Dr. Hatem Soliman, for this really interesting presentation. I have really enjoyed every single word you have said.
Thank you, Dr.
I have a question, please. You have said that you depend mainly on lung ultrasound for extubation for ventilated patients. As you know, lung ultrasound is not available in many countries, and no many experts in this field. What do you suggest to depend on to extubate the patient? Can we ask for CT or X-ray, or you depend on the saturation, blood gases?
Yeah, of course.
As an alternative for the lung ultrasound.
Yeah, of course. I mean, if you don't have lung ultrasound, of course, you will rely on the clinical information. You will use the chest X-ray, but the idea is the same. You have to give the patient time. And I mean, as people observe, there's no evidence on that. This is all experience-based. 10 to 14 days, some people do after 7 days. If you see your patient clinically ready, hypoxia is improved, X-ray showing reduction of the infiltrations, yes, you can use the clinical and X-ray criteria and guide your extubation. Lung ultrasound is not a mandatory thing to do, but it is useful if you have it to utilize it.
Can I just give a comment here? With lung ultrasound, things are completely different compared to CT scans and to normal echo. The worse is your machine, the older is your machine, the less artifact suppression algorithms it has. And you see the B-line is much better. So you are actually not restricted by the fact that you have just old technology. You can just find an old echo machine in your unit. You can dedicate it for a COVID patient to avoid disease spread. And it's much easier to learn lung ultrasound than, for example, transthoracic echocardiography. So I think anyone who's dealing with this patient has to start doing it, and that there's no limitation based on machines and availability of machines. Just find some old machines and start doing it, and you'll get used to it, patient by patient, patient by patient.
If you have a machine, you can definitely learn it, and it doesn't take time to get yourself able to do it. But I mean, your question is mainly if you don't have a machine. So if you don't have a machine, your world will not stop. You will do the same thing. You will assess clinically, you will do the X-ray, but the main thing, be patient. This is the only thing we know about COVID-19 respiratory failure. Be patient. There is no evidence that any of the medications work so far. And we saw patients that improved without any treatment, without hydroxychloroquine, without azithromycin. They just had their time on the ventilator and improved and extubated. And a lot of them we saw, they went home successfully.
Great. Dr. Muhammad, can we have the question from the audience, please?
Okay. So, question from
our colleague, Dr. Fadi Aziz. He thanked you for your great lecture, Dr. Hatem, and he is asking if you recommend increasing PEEP levels up to 20 centimeter water in the H type for further recruitment of the lungs. If they are on FiO2 80%, or would that reduce the venous return?
I mean, I cannot recommend a number of PEEP because this is very variable, and we intensivists know very well that when you apply PEEP, you should apply it in a gradual way in the setting, in the light of the FiO2. So we have the table for the correlation between PEEP and FiO2. So, and again, when we apply positive pressure ventilation and give PEEP for recruitment, we have to carefully assess the right ventricular function. So I can never recommend giving a number of PEEP without knowing how much FiO2, how is the clinical condition of the patient, how is the blood pressure, and how is the right ventricular function. So it's not that easy, I'm afraid.
Okay, another question from the floor, Irina Iki. She is asking about your protocol in treating COVID. Do you use antimalarials? Do you use azithromycin? Your opinion about the antivirals, favipiravir, remdesivir, and the immunoclonal antibodies like tocilizumab. Do you use these agents in your daily practice?
So far we only, initially when the pandemic started, when we started getting patients in our hospital, we had an agreement that we will start with hydroxychloroquine and azithromycin as a protocol to our patient. But then we noticed a progressive increase in the QT interval to dangerous levels in these patients. And then when we started to see reports from our colleagues that, yeah, we know that from the start that there's no evidence behind this. So we started to stop them one by one. And currently we don't have recommendation in our place to start any of these medication. I have no experience with the antivirals, and I have no experience with the immunoglobulins in COVID-19. So my message is clearly, I see that these patients get well with time on the ventilator with no specific treatment. I have no clue about any specific successful therapy so far.
Maybe complementary to this question, did you see cases with myocarditis?
Yes.
Where did you think about using glucocorticoids or immunoglobulins in these cases?
Yeah, we do so cases with myocarditis, and we even used immunoglobulin. We used steroids in patients with the type H, so not even with myocarditis. Again, there's no evidence. It's all clinical-based, experience-based practice. We heard from our colleagues in Italy and Spain that a small dose of steroids can be utilized in patients with the type H, and we do use it sometimes in some patients. And I'm not sure if this is the cause of their improvement, but I had 2 very sick patients on the unit, extremely sick. They were the type H, they had the cytokine storm, they were elderly. They were 2 among other very sick ones, but these 2 patients recovered and improved. And one of them had tracheostomy and the other one is extubated. I'm not sure if steroids is the cause, and I doubt it. But the answer to your question is, we sometimes feel when we see the patient is very unwell, we use 1 to 2 milligram per kg of methylprednisolone for a very short course.
There is another question from Dr. Muhammad Abdul Wahab. He is asking about the role of non-invasive ventilation in treating L-type as a primary mode of ventilation.
Yeah, I think this is a good question. I think the L-type, we see patients, intubated with 40% FiO2 and people of 8. And we think that they could have been managed successfully with the non-invasive ventilation. So I think non-invasive can be useful in this patient only if it offloads the respiratory function. If the patient works hard with the non-invasive ventilation, I think it's not a good idea to continue with NIV. Otherwise, they will have the self-inflicted lung injury that we discussed in the presentation, but if NIV succeeds in offloading the respiratory pattern and improving the breathing condition, I strongly recommend NIV.
Okay, I think it's clear now. Other question from Dr. Hasib Breda. The question is directed to you as well, to Dr. Alexander, if he would like to share the answer with you. Do you have a comment regarding plasmapheresis in COVID patients?
We haven't used it. I don't have experience in it. In
Dr. Alexander, maybe?
I've never used that. Theoretically, it should work. We don't have enough patients in Bulgaria, so we have very few patients here. We have like 800 official patients and about 40 deceased patients. So we've not developed any pool with that. So we are waiting. I think they're planning to use that in US. And they have plenty of cases in New York, so I hope they'll publish their results, and we see how it works from that.
We will see. The next question may be to you, also, Dr. Alexander. Do you see any difference in anticoagulation regarding the prophylaxis of VTE between L and H types of COVID patients?
I think the main difference there is how to ventilate and how to manage the patients. I would be more aggressive than with the normal patients in both types. I think this disease is very prothrombotic. Of course, I speculate here and I can't prove it, but the minimum of the enoxaparin that I would use would be 40 or 50 milligrams twice daily in a normal size man or woman. Otherwise, if it's a heavier man or woman, I would go to higher doses.
Okay, I think we are done with questions from the
maybe I have one thing to mention. Probably we didn't discuss. It might be related to the plasmapheresis question.
Yeah.
We have experience, and we used several times the cytokine absorption hemofiltration, and I'm not sure again. This therapy is very lacking in evidence, and globally only case reports available on this. But again, the two patients that I saw survived and were very sick and had steroids, they were both put on extended periods of cytokine hemofiltration. And I do feel that even before the COVID-19, from our experience with cytokine absorption, that there might be a benefit, might be a clinical benefit from it. But I'm not quite sure again, but I think maybe it's important to put it in consideration.
And something else I would like to mention, certain parts of the patients will develop acute kidney injury, and they will require renal replacement therapies. And it has been reported by many colleagues from Central Europe and Italy that the machines get clogged. So even on heparin, even on high doses of heparin, even on citrate, it happens.
We see this a lot. The filter clots very frequently in these patients with high dose of heparin, and it is a very aggressive disease in terms of thrombophilia, and that's very correct. We struggle with them sometimes with anticoagulation. Even we had to put patients on argatroban sometime because when they fail, when they don't respond to heparin, and some of them have liver failure, we don't have the option of using citrate, so we put them on argatroban. And that's probably the only thing that worked well with some of them.
Great. At the end of our webinar, I'd like to express my deep thanks and gratitude for Dr. Alexander Nossikof and Dr. Hatem Soliman for their excellent presentation. And I'd like to express my deep thanks and gratitude for my co-moderator of the session, Dr. Abdallah Al-Maghrabi and Dr. Muhammad Hamdi. And see you in another webinar soon. Thank you so much.
Thank you so much, my friends. Stay well and safe. Bye-bye.
Thank you. Thank you.
Bye-bye.
Bye-bye.
Bye-bye.